Women in your 30s and beyond, are you tired of being told how to feel? Like all of the products are forced on you? Doesn't it feel like these big companies categorize you when the truth is they don't know you? If anything I just said struck a nerve, listen up. I'm Dr. Jila, an OBGYN and women's health expert. This is my podcast, Her Time, Her Health with Dr. Jila. So I'm going to jump right in, Dr. Liz, and I want to ask you, as a newly graduated healthcare provider in the primary care field, as well as obesity medicine, you're dual board certified, so you're going to be taking care of all kinds of patients.
I'm taking the
boards
in October, but yes, eligible.
But you're almost there. You're almost there,
yeah.
It counts. When you hear I want to talk about women's health more today than anything else.
Yes.
And the whole overall look at it and get your perspective as the younger generation, because you are what we as the older docs are looking at. We're looking to you to guide these women through their midlife journeys. So I want to get your perspective. I want to know how it is out there in the younger population, and how do they see it? What do they see? And kind of how do they feel about it? When you hear the word perimenopause, what comes to mind? Does it feel relevant to you right now? Or is this something like so far off that you don't even think about it?
I definitely think about it because I'm 29, turning 30 soon, and this is the decade that I could potentially start having symptoms myself. You can start having symptoms 10 years before your mom actually had menopause, and that would be my late 30s, for example. So it's very relevant to me personally, and it's also relevant to the conversations that I am having with young women during their annual visits in their 20s and 30s.
Amazing. So you said about 10 years or so before, so you spoke with your mom already about this topic, right? That's amazing, because I think that helps quite a bit navigate your journey and how you're going to be going through it. Talking to mom, you have a point of reference. Okay, mom, when did you go through this? How did you feel? Did your mom take hormones?
No, she did not take hormones.
Mm-hmm.
And I have a story. So I recently had a graduation party, and it was so lovely. My family put it on for me. And my mom had the idea of collecting cards, and people were going to write things to me, either questions as a doctor or to make videos about. And I had more than 5 cards from women that I know in their 50s and 60s that said, please talk about menopause more. It's so taboo. It's not something that we talked about with our moms. And so there's a lot about menopause now on social media, which I think is wonderful. But what I think everyone should know is that it was very recently very taboo, and nobody was talking about it.
Right.
And there's a bunch of women in my life that I love and are so important to me that didn't have that opportunity to have open conversations with their mom. And so as a doctor, that's something that I want. That's something that I want my sister and I to do. So I think that is a generational shift.
Yeah. And it's only going to shift more going forward, especially with providers like yourself who are well-versed. You are more educated than my generation was in this realm of the whole women's health and the WHI coming out and everything. So I think that is critical to understand that the goal is of what we're doing, this grassroots movement basically, is to allow your generation to ease through it, make it more accessible, and that women are talked to about hormone therapy when it's appropriate, how to take it, and they're not just shunned and dismissed and told, you're fine, it'll be okay, you just have to suffer through it, and you'll end up on the other side, however you might be at that point.
Or it's just a natural process. You're supposed to go through it.
And you don't need anything, and it'll be okay.
Yeah.
So I think that's really eye-opening that you had that many people give you that advice.
I know. And I know them all. And that's not something that I would guess, but it was shocking. But it's true.
So let me ask you this. Then how do you feel? How well prepared do you feel coming out of training right now in terms of discussing these topics with your patients when they come to you? There's 2 big taboos. One is the menopause discussion, right? The whole it's not happening to me, or because if it is, I'm too old and I'm reproductively not capable anymore. And the other side of it is the sexual health component. Those are the two
Mhm.
big taboos that we see with women's health. So,
Yes.
how prepared do you feel in regards to educating your patients?
I would say that the opportunities were there in residency, but it's something that you have to seek out yourself.
Mhm.
I think it should be more mainstream. I would like primary care to do more menopause care
Mhm.
because I think OBGYNs are amazing and they're the specialists at hormonal therapy, but women see all specialists. And if anything, they can get into primary care so much easier
Mhm.
and faster. And so I would love for primary care curriculum and family medicine as a whole to adopt menopause care much more. And I think we're making good progress, but I think there's room for improvement.
Okay.
So I received 1 grand rounds on hormonal therapy that was given by a resident. And then I was able to rotate through a clinic through the
Mhm.
OBGYN department where I went. And that was great learning.
So
But
you
there's
had
a lot
hands-on training with the hormone therapy and everything?
for estrogen and progesterone, yes. But you have to go out of your way. It's not presented to you. But that's a lot of things in residency. It's like
Right.
self-driven learning.
Mhm. Basically, you find out what your passions are in that field because
Yes, exactly.
you're a primary care physician. You can take care of everyone at any point in their life, basically,
Yeah,
from
but
when they're younger all the way through.
yes. You end up honing in on something that you really enjoy, and for me, that was women's health, and
Mhm.
not just women's health in the reproductive age period, but midlife and beyond,
Mhm.
and recognizing in primary care from day to day the issues that come up, like recurrent UTIs, and asking, has anyone ever offered you vaginal estrogen? Have you ever heard of genitourinary syndrome of menopause? Did you take hormones for menopause? All those things come up in primary care clinic all the time. And I almost saw it as fun to be a resident that honed in on that and had the solutions. And
Because, like you said, there's only so many OBGYNs and there's only so much we can do. And a lot of us are still delivering and operating. So then, where is that specialized gynecologist who can help women in midlife?
it's at the community level.
And to
Mhm.
have our counterpart primary care providers able to do the same kind of care and have those discussions, it's only going to help more women. I
I
think
think it's absolutely necessary.
it's
Yes.
necessary. It's for
Yes.
us, it's for PCPs, family practitioners, endocrinologists, because again, they're also dealing with hormones. So why not bring
Yes.
them all in to the whole
Oh,
part
of
of the
course. We
women,
love endocrinologists.
right?
Yes. Everybody should be doing it.
Should be doing
Yeah.
this. Exactly.
Yeah.
So I think that's your patients are going to be that subset of patients who are going to have access to that from somebody as young as you. And that's rare to find, but hopefully going forward, there's going to be
Yeah.
more.
Hopefully.
Right.
I saw enthusiasm in my co-residents as well, and I think all of the noise that people are making on social media, or not noise, positive change,
Mhm.
is really a big driver too, because everybody's on social media.
And again, and I
Yeah.
think it's become a platform to allow all of us to be out
Mhm.
there educating, but the right people educating, because there are others who are not really. This isn't their this is not a niche. This is real care. This is
Yeah.
medicine, and it's not something you learn over the course of a weekend. This is something you learn long term. You
Mhm.
take courses. You have to be proactive in looking for this information. And it comes from all different sources, basically. It takes a specialized individual to really have that intuition to go after it. And I think you are somebody that I have seen evolve over the past few months. And I'm like, she's got this. She is coming out. She's understanding the complexities of women's health in terms of even with the IUD component. How do you insert an IUD without causing
Yes.
trauma to a patient?
Yes. Exactly. And that's another we could go down that road. I think that primary care doctors should also be good at just basic gynecologic procedures
Hmm.
because you should be able to take care of all of her, including long-term reproductive care, such as putting in an IUD or an Explanon or handling the complications, knowing when to refer.
Oh,
Yeah.
and it only helps women have more access because,
Mhm.
now instead of just having one doctor take care of them, they have two. And they can go to you as their primary care physician for everything. And like you
Mhm.
said, if there's an issue, then you reach out to your friendly gynecologist and say,
Exactly.
listen, hey, by the way, this and this I did. Now this is happening. Do you want to see her, or is there something different I need to do, or do I just monitor her for this issue?
Exactly.
Yeah.
Just the way we collaborate in a hospital,
Right.
coming from residency, I think that should happen on the outpatient community side too.
100%. I think that's the only way women are going to get that overall holistic care that they need,
Yeah.
especially in
Yeah.
midlife going
Yes.
forward. Okay, let me ask you this. Do you think a lot of your patients are able to pick out the symptoms of perimenopause when it's happening to them? Or do you have to open up their eyes to it?
No, I think we have to open up their eyes to it. I don't think everybody puts it together
Hmm.
because I don't think that we have that much education about it in general. I We don't get that much education about menopause in medical school. We really don't. And in residency, I got more because I was at a family medicine program. If you go to OBGYN, then you probably get even more. But
Hmm.
there's a lot of doctors who in specialties that get no menopause training at all, like at
Right.
all. No, yeah, you definitely have to educate your patient and just link it together for her. But this always brings up the factor of there's things that you wish could happen in the room, and then you realize you also have 15 minutes. And so this also comes down to continuity of care, just really knowing your patient and hopefully having seen them for a long time. And one visit you talk about she's feeling down, she has depression. Another visit, she opens up to you a little bit more and she says, I really don't have a libido at all. And it's impacting my marriage. I love my husband. I just don't know what's wrong. Another visit, she starts saying, "Oh, I wish I could do something about my weight. I don't feel like I've done anything that different, and I just have been putting on weight, and I can't explain it." And yeah, no, there's all these different things that come up. You find out she has a family history of osteoporosis in her mom. Things that just piece together that make people lower risk or higher risk for complications during menopause. And you get that over time,
Hmm.
hopefully. And then you piece it together.
And you explain it to them what you're going after, right? Because it's not just about
Mhm.
not having a period or having a period or cycle irregularities and hot flashes. There's a lot more to it than
Yeah.
just that.
Mhm.
And to be able to understand that and be like, okay, I've seen you over the past few months and you're complaining about this and piecing it together for her. And then the light bulb goes off saying, okay,
Mhm.
maybe I am in perimenopause. I didn't know that.
Mhm.
And now they have you who can provide assistance, whether it's lifestyle modifications or whether
Mhm.
they're a candidate for hormone therapy at that point, then those are the discussions that you have going forward. But I love the fact that you're able to piece it together for them. That way they're not lost. They're not searching at 3 in the morning online to try and figure out what's wrong with them.
Exactly. And I just wish more women would have access to a longitudinal primary care physician or OBGYN. It just that's the perfect picture, but I think unfortunately for a lot of women in the US, they just don't have access to care with everything that's going on in the
Hmm.
country, and then also that there are just not that many incentives to go into primary care at this time right
Hmm.
now with everything that's going on. So we have a primary care physician shortage. We have a shortage of honestly all the specialties, but
Right.
especially primary care. Yeah.
Yeah. And that's only going to kind of have a snowball effect, I think, going
Mhm.
forward for women in general, right? Everybody, but women in particular, we've been sidelined for quite a long time.
I
And,
agree.
we're finally coming out and we're getting research studies done and that relate to women in particular, not done for men and then, oh, let's apply it to women. Why don't we just kind of really look at research involving women, long term studies to see what is going on? Are there risks to what we're talking about? And
Mhm.
little by little, it's coming. And listen, last week we had the FDA meeting,
I was
which
gonna bring
was
that up. That's
it,
so cool. Wow,
it's
we're
a
talking about a women's
groundbreaking thing.
issue.
Right.
We're all coming together to talk about a women's issue. That's great.
That was monumental. Hopefully, it will go in the right direction. It'll be the first
Mhm.
of many where women's health issues are addressed and things change for the betterment of women's health. We're
Mhm.
living longer, but we also want to live. We don't want to just
Yes,
live long, have health issues. We want to be healthy living
exactly.
those longer years.
And I was so impressed to hear about the reduction in recurrent urinary tract infections, which decreases your chances of sepsis. And there was
Mhm.
a mortality benefit in vaginal estrogen, which I think should be in every primary care doctor's toolbox. I think
Yeah.
vaginal estrogen should just be on the top of everyone's minds in a postmenopausal woman having
Mhm.
any kind of urinary symptoms or dyspareunia, painful sex, or pelvic floor issues, anything.
Right. And the thing is, to be honest with you, right now, most women should be on vaginal estradiol cream. That's just a given. It's not if that, it could be a preventative measure, and that's how it should be looked upon,
Mhm.
even in the early menopausal women, because some are like, I don't have symptoms. Okay. But let's not wait to have a major problem to start something. Why don't
Mhm.
we try and be proactive and preventative?
Mhm.
With all the data behind it that we know that it is safe. It's safe enough to use in breast cancer survivors. So that should give us enough information.
Yeah, that's what I was gonna say is that along with training to prescribe it more often, there should be training in discussing and counseling about the risks involved and
Mhm.
actually knowing what the risks are because, for example, you have a patient who's had a history of a venous clot,
Mhm.
and you're discussing vaginal estrogen, and you would hope that a physician would feel comfortable just counseling her on the risks, how it's actually not systemic,
Mhm.
and you have had a chance of a clot in the past, so there is that in the background, but it would actually be safe for you to use this topical estrogen,
Right.
and some people actually there's a lot of difference in practice, I think. Some people just won't accept that risk as a prescribing physician and just wouldn't prescribe, and, yeah, that's why we need more training too.
I think that's where it's at. It's understanding that it's localized vaginal
Mhm.
estradiol cream. This is not systemic, and hence those risks do not apply to this. But they don't know that. And so it's that fear of hormone therapy, estrogen, no,
Mm.
clot, bad, and they run the other direction and
Mhm.
scare the patient out of using it.
Yeah, or anything else, like a first-degree relative, like mom or sister had breast
Hmm.
cancer, and all of a sudden, "No, we're not doing hormones
Right.
anymore."
Right.
There should be a much longer discussion, let women make decisions about their own health,
Mm.
and maybe she's willing to accept that risk,
Right.
and give her the risk, and then that's up to her to decide, honestly, that's how I feel.
I think the reason we're all here is we're not pushing things on women. We're just giving them the
Oh, of
data. We're
course, yeah.
giving them the education. We're giving them the studies. We're breaking it down for them to understand and then make their own choices. But a lot
Yeah,
of docs in our communities aren't even allowing us to do that.
and that's paternalistic. It's
Yeah.
very paternalistic, even if it's implicit. I'm not saying anyone's doing it intentionally, but
Right.
we should recognize that.
Yeah. I've had quite a few discussions with the community docs here, and it's some of them are willing to look into it and learn for themselves, and others not so much. But that's okay. The patients are figuring out where to go and what to get and what to ask for, I think, and
Yeah,
that's what
and
it's at.
other people will just keep posting.
Exactly. We're gonna keep using our platforms to educate
Yeah.
and give the right information there. How do you feel about the hormone therapy and protecting long-term health in terms of longevity and well-being, heart health, bone health, brain health, cognition? How do you feel that relates, and how do you again, you're on a lot younger, 20 years, 30 years almost younger than the rest of the people here. And some of you're younger than some of the patients you're taking care of.
Oh, yes.
How do you relay the importance of this in terms of how they are going to be later?
I think my style is you need to follow up and we need to have a continuous conversation. And I, again, present to them all of the information that they need to know. And during your counseling, and hopefully people are doing this counseling, that estrogen is so protective for
Mhm.
so many different parts of your body. It's not just about treating vasomotor symptoms. I did a video with Dr. Susan Bryan,
Mhm.
endocrinologist who I love. And we talked about how estrogen is protective for osteoporosis. And it's actually FDA labeled for that.
Right.
And I don't think that we talk about that enough either, that we can prescribe estrogen for osteoporosis. That needs more hype too.
Hmm.
And osteoporosis, I did family medicine. We do a lot of family medicine inpatient. So I did a lot of, which is basically just general medicine.
Okay.
And the number of femur fractures that or fragility fractures that I admitted, it's just you admit and then you consult ortho for surgery. And it was always ground level fall, elderly population, mostly female. Nobody's on hormones at all. That's also, I went to a residency, did training in Appalachia, which is rural central Virginia, and rural healthcare in America. You're always talking about accessibility and education. And so nobody's on hormones at all. And so that also fueled me wanting to talk about hormones in clinic, just seeing what happens from complications such as breaking your leg and then having an extended hospital course in your 60s and staying in any hospital, you're getting complications and such as now I'm going on a tangent, the complications that happen in the hospital, you get pneumonia
Right.
and you lose, I think, 10% of your muscle mass every week that you spend in the hospital and the amount of rehabilitation that you have to go through. And it's just so much harder when you're older and you don't have a lot of skeletal muscle mass. And I guess what I'm getting to is the overall survivability of women. Being on hormone therapy will potentially keep you out of the hospital from urosepsis all the way to a fragility fracture.
Mhm. And the thing is, even Dr. Vonda does say that a lot of women, 40% don't return to baseline function after a fracture like that.
Oh, yeah.
That and she operates on them daily, and it's disappointing, and it's so disturbing to see these
Mhm.
women come in, and like you said, majority are not on hormone therapy, where
Mhm.
something and it's preventative once again.
Yes.
Had they been on it, then that wouldn't have happened, and that goes to
Yes.
our screening modalities. Doing a bone density at 65, that's the
It's so
recommendation.
late.
You're too late by then.
It's so late, and bisphosphonate is in every primary care physician's back pocket,
Right.
and I wish that estrogen would be in our back pockets, but 10 years or 20 years before we get to the bisphosphonate at 65 after
Right.
the DEXA comes back.
We could have been on estrogen and avoided the whole thing and never
Yeah,
needed to
what
be.
about
And
that?
the thing is, go back to before the 2002 study was published, estrogen was in everyone's back pocket. Everybody was
Hmm.
on Prempro. You're going through the change, you get Prempro, you get this. There are
Oh, that's
different
so
versions.
interesting. Yeah, I just don't yeah.
Yeah. And then now all of a sudden, it switched overnight. Prescriptions for hormone therapy dropped by 84% overnight
Oh.
from those headlines.
No, yeah, my mom was never offered that, and my grandma was definitely not on it.
So these are the
I wanna be on it. I
conversations.
think I'm
No,
gonna
no,
be on
no.
it.
You're like, I think I'm so to be honest, or moving forward, you will it's
Mhm.
not going to be a discussion. It's going to be, oh, you're in perimenopause. Okay, let's switch you from this to that. Or now this is the discussion. You're going to be ready for it. And you're going to
Yeah,
be searching it out at that point. You're not
yeah.
going to struggle. Like we had to find our own.
Hmm.
I had to go through different ways of researching to figure out what's going to work for me. And so
Hmm.
that's where my fuel came was like, okay, if I'm struggling, God, I don't want to know what's happening to other patients out there. And I'm
Yeah.
in the field. This is my field. And we didn't know it. So it was really jolting at that point to be like, oh, why am I missing such a big piece of this?
And we prescribe birth control for younger women
As if it's nothing.
as if it's nothing, and it's higher dose of
It is.
estrogen, progesterone.
Yeah. And
We
it's
prescribe it like
synthetic.
it's nothing.
Synthetic versus more bioidentical.
So
Yeah.
I just think it's about training, and there's just been can we say it? Can we say a brain drain when it comes to menopause
Yes.
training for the
100%.
past 10 years? And now it's revving up again, and I guess I'm straight out of residency, and I'm part of it, but I'm jealous of the ones who are gonna get it a lot of it in the
Yeah.
next 5 years, which is amazing. We want that.
The thing is, imagine, go back to when we trained, there was nothing. And it was less. And now you guys are the first population coming out where it's like, there's more. And there's going to be more. So that's where it's at. And they're probably going to ask you to go back and give grand rounds on it next,
That
because
sounds
you're there, you're in
yeah.
it, and you're on the front lines actually prescribing. So you can actually talk to what it is, what it's like when those patients come back and tell you, you saved my marriage, you saved my life.
Yeah,
I'm back to being me again.
I know. I love when people come back and say that. It makes me so happy.
Because was it a hard thing to do? No.
No.
I tell them that. I'm like, this isn't rocket science. This just needs
Yeah.
to be somebody who is well-versed in it. That's all.
I have to say that you, Dr. Jila, and a lot of other people have been so amazing on social media. I have to applaud you because you teach a lot of people. You have a lot of people who follow you, residents, learners, medical students, and all of you guys have been making content that is very educational. And so thank you. It's been really great. I found you, I don't know how long ago, maybe 9 months ago, a year ago, and I just stumbled across your page and I remember thinking, wow, I love everything she's saying. And I learned so much from you. And so it's been great. I'm so happy to be here today.
Thank you for being here. And this wasn't my thing, right? I am not a social media person.
You're so good at it.
You know what it is? You realize it's actually helping people. And then you just become fluent at it.
It gives you a mission. It gives you like you get behind a voice, you get behind a purpose, I think,
right.
as a doctor, because you're not just an influencer, you're an expert.
And in my practice, I'm seeing 20 to 30 patients a day. So I'm taking care of that many. But with this platform, we can get the message out to more people.
Yes.
And do I see all of them? No. But do they have questions that I can answer? Sure. And maybe that one question that I answered for them and pointed them to the right resource of go see this individual or this person will help you, help them enough. I think that's the push behind why we do what we do. And how we become fluent at it is because, okay, you know what? It's fun. It's easy. And again, it's just us talking. This is authenticity at its best because I'm just saying what I say in my practice. So
exactly.
This is what we talk about all day long.
I know. And my favorite part has been building the community. It's been unprecedented for me. I have met so many amazing physicians specifically. I've connected with hundreds of doctors and that are all different specialists, and we have so much to learn from each other. And from cardiology to neurosurgery to OBGYN to other family doctors, actually to so many different doctors. And I'm learning a lot from different obesity medicine doctors. And so I think the community, other than the purpose and the message, I think the community has been absolutely beautiful part of social media.
It's basically you have access to other providers. You have access to experts, and you can just reach out.
We're all communicating, and we're all openly talking and asking questions and learning from each other. And it's almost like a curbsiding consult
with your providers.
Hey,
Susan, I have this thing going on with this patient.
Yeah, exactly.
What do you think about that? That's all it is.
I literally asked Dr. Bryan, a patient with an IUD, she has uncontrolled PCOS. I was thinking of starting OCPs on top of her having an IUD, and we just talked about it, and it was like this is the second time I mentioned her. Obviously, I love her.
She's great. No, Susan it's funny. I came across Susan on social media, and she had made a post about how she came on, and then it was just too much, and she didn't think it was working, so she came off of it.
I know.
And then she came back on, and I reached out to her. I said, listen, I think we should talk about the endocrine side of this, and what do you think? She goes, sure. So we did a live together. And afterwards, I told her, I said, you're great at this. You shouldn't give up on it at all. Just keep doing what you're doing. Yeah. She is, with the studies, with the quotes, with that. I'm like, oh my gosh. You're it. You're the one everyone's going to look to for the studies. So I think you're doing yourself a disservice and everyone else if you don't.
Yes.
So I love her.
That's one of the things that she teaches is evidence-based medicine and how to read a paper. And she discusses the strength and everything. And I learned from her. So it's been great.
No, every time the GLP-1s come up, I'm like, wait, what did Susan say about that study? Okay, yeah, that's the one. We're gonna, and I reach out to her. I'm like, okay, so what'd you think about this one? And did you go through it? And she's like, yeah, that one's good, but this one not so much. And there's more coming. Just hold on. And I'm like, okay, then we're gonna do that. Oh God, yeah, no, we're gonna talk about all of them.
Okay.
What would you say in terms of what kind of conversations would you have with the younger patients? So we talked about the
Mhm,
older patients that you see. Now go into like the 20, 30-year-olds that you're
mhm.
seeing. How would you guide them or set them up with a roadmap as to how should they, per se, optimize their 20s and 30s? That way, when they hit perimenopausal
Mhm.
times, like 40s, right? They have all their ducks in a row and they can glide through it easier.
I love talking about this. It's during every annual visit that I have with women. I tell them, "I know that you're 22 years old, but just come and see me once a year. There's always something to touch base about, even if it's 30 minutes, and we're gonna talk about multiple things. We're gonna talk about sleep and nutrition, and are we do we understand macros? Are we aware of the importance of protein? And we're gonna talk about cardio, but we're also gonna talk about strength training because nobody talks to women about strength training.
Mhm.
I know we're surrounded by everybody who's on social media, we're all talking about
Right.
it, but out in real life, people are not
It's not
talking about
happening.
it. It's not
Nope.
actually happening.
Mm-mm.
So we talk about strength training. We talk about family history. What is your relationship like
Mhm.
with your mom? Do you guys talk about that? What was her menopause journey like? And those conversations are happening more in women in their early 30s. And then another thing that women actually have to talk about that I talk about in primary care is what are your thoughts on reproduction? Where would you like to go with that? Do you ever want to build a family?
Mhm.
And it depends on how old they are. When did your mom go through menopause? Because symptoms can start 10 years prior to going through menopause. And women do have a time frame for when they would need to reproduce. And so it's just starting to plan ahead. Now we have such amazing advancements such as IVF, and you
Mhm.
can harvest your eggs and you can save them for later. And so there necessarily isn't a time frame of when you need to have kids. It's just about planning ahead and being cognizant of that. And so if you wanted to have kids later in your 40s, you can do that now, but let's talk about what that would mean to prepare for that. And that is all surrounding menopause talk.
So
Yeah.
basically, you're setting them up for success when they
Mhm.
get there. Because as we know, your muscle mass, your bone mass, all
Mhm.
of that, it peaks in your late 20s, early 30s. Like you really
Yes.
get that peak bone mass early 30s. And after that, it's going to still increase, but not as much. And then you start losing it once you start
Mhm.
going through perimenopause. So to have that all optimized and just at its best, knowing what,
Exactly.
like basically, it's not all cardio because that's what we're taught. It's
Mm-mm.
all skinny, skinny,
Yeah.
this, that. We need to change that whole
Oh, yeah,
discussion.
and let it go on record that we don't do diets anymore. That's not
Right.
what we talk about in clinic.
Mhm.
I wish that everybody had access to a registered dietitian. That's why I love listening and learning to registered dietitians because they have so much nutrition training that we don't have in medical school because we're not nutritionists.
Right.
I need to come out and say that as well. We are not
Yeah.
nutritionists. We are medical doctors, and we should all work together to optimize a patient's health. And so we have a lot to learn from each other.
Mhm.
But the nutrition counseling that I do in clinic is all surrounding let's switch from our culture of a carb heavy kind of food diet. Let's switch it to a protein centric kind of diet. And
Mhm.
we're not going to do where we cut things out. We're going to do everything in moderation so that we can do it for a long time, for the rest of our lives, actually. When you go to eat a meal, I want you to think about what's the protein in this meal? What's the fiber in this meal? And we can't demonize carbs anymore. We cannot
Right.
demonize carbs. It's not about demonizing carbs. I don't believe in a low carb diet. I think people have their reasons for it. I'm sure someone could give me amazing reasons for a low carb diet. I'm very open to hearing them out, but it's really about total calories. And
Mhm.
I, where I'm coming from is that I'm not trying to stress anyone out. It's not supposed to be difficult. It's not supposed to make you feel guilty. It's just supposed to be a philosophy in which you live your life. And it's just to eat better overall and
Right.
to have a focus on protein.
That's why
Yeah.
they're lifestyle modification. This is something
Mhm.
you're gonna live with for the rest of your life. This is not a
Yeah.
fad. It's not a
Mm-mm.
phase. It's you need to put these changes into place little by little. It's not overnight. It takes some time, but
Exactly.
imagine
It's a
starting it in
goal.
it's a goal, starting it in
Yeah.
your 20s. By the time you
Yeah.
hit mid-30s, it's automatic for you.
It's
You
on the
don't
back.
have to
It's like the
think
back of your
about it.
hand. You don't have to think about it
Yeah.
because you got into that mindset when you were younger.
Mm.
And I grew up early 2000s, late 90s, early 2000s, and there was such toxic culture about being skinny and you walk around the house, don't eat that bread, don't eat
Right.
the crackers. And it's just the way everyone was. And I think it created such a sense of shame and guilt surrounding being skinny rather than tying it to being healthy and strong. I don't think anyone was walking around saying, oh, girls who are strong are so attractive and hot. It was more like, oh, look how skinny she is. She's so hot. That was the early 2000s. And now I think we're changing. I'm 29 and I think the younger generations are seeing a different side of social media that's a lot more body positive, such as we're getting way more into women's sports now too. I open up my Instagram and it's Caitlin Clark or Ilona Maher, and now it's sexy to be strong, and that goes really far in clinic when we're counseling that strong is powerful and increases your survivability as a human being. And we're getting away from limiting ourselves to specific diets and we're getting into lifting weights. And you can walk up. I hear a lot of my patients say, it's so intimidating to go to the gym. But I hear a lot of my patients say, but it's so intimidating to go to the gym because that's where all the guys are when you're lifting weights, like they're taking up all the space. And I hear them and I feel the exact same way. So there's a lot of counseling and coaching that goes into that. So when we're talking about strength training to prevent menopause, or we're talking about strength training because you're in active weight loss and you're trying to build muscle, there's a lot of, I think, compassion and empathy that primary care doctors need to have and do bring to the table. And that's something that I focus on too.
So,
I feel like I naturally just have a lot of younger patients too. I think it just goes
yeah.
that way when you're first starting out.
And so I think they're also they kind of are attracted to you because they're like, okay, I want to know from her perspective, what do I need to do to be the healthiest in my
Mhm,
life and with my goals? And I think having that persona, that empathy, you spend the time with them
mhm,
and set reasonable goals. Not you need to go do X, Y, and Z and then come back and see me. It's not go eat this much protein and come back. You actually break it down for them in a manageable way where they can understand, okay, this is what I need to do. This is what I should be doing. Can you give them a meal plan? No, again, we're not nutritionists,
mhm,
but you can guide them because God,
mhm.
thank God social media is there because you
Oh,
can
yeah.
find meal plans. The Mediterranean meal plans are right there and they're easy, they're
Yeah.
delicious, and you make
Mhm.
them and just do that or follow that account or things
Oh,
like that.
yes. I do that all the time.
I
Oh my
do too.
gosh.
I write it
Oh, my
down for
phone's
them.
on
I'm
me.
like, this one,
I'm like,
go
"Have
to
you"
this one.
yeah. "Have you followed" I ask them, "Are you on social media?" "Great." And then I pull up my own phone because it's always on me. "I love this registered dietitian's account,"
Mhm.
or "I love this strength coach's account," or "This obesity medicine doctor, he, like, teaches so much, you should follow them, blah, blah, blah." I'm always doing that
Right.
constantly,
And guess what?
constantly.
They're on their phones too. So these are free resources that they have
Yeah.
access to.
And if you're gonna be on social media, you might as well make it educational. Yeah.
Exactly. Okay.
Yes.
Oh, that's where it's at for the population going forward and being
Mhm.
healthier. They're
Oh,
gonna
yes.
be ahead of the game with all of this. They're gonna
Mhm.
be at they're strength trained. They have their lifestyle modifications in check. I already am noticing the alcohol shift happening in the younger population. They're not drinking. They're not drinking the
Mhm.
way that they used to in college. It's not happening anymore. They're already thinking about it.
That's something that I talk to everybody in their teens, 20s, 30s,
Mhm.
40s, 50s all the time is substances because that increases the aging process and
Right.
makes you more frail and you lose skeletal muscle mass and it increases your chances for malnutrition and all the things, insomnia, fatigue, all of that. So we're always talking about alcohol and cigarettes and we haven't even talked about vaping is a huge
Vaping, yeah.
problem.
Mm.
But I do think that you're right. There's a general shift towards people becoming more health conscious because of the information age, I think, because of
Mhm.
all the social media.
Yeah, but they're seeing so
Mhm,
much out there in terms of well-being,
mhm.
longevity,
And now it's
living
cool.
longer. Now it's
Mhm.
super cool.
There's a bunch of wellness influencers. Now it's
Like
cool.
Brian Johnson being out there doing all of that. I want to do what Brian Johnson does. And
Oh,
again,
no. We can't talk about him.
extremes. We get to extremes. I'm like, okay, there's a middle ground here. Let's
He's
stick to that.
extreme. He's very
He's
extreme.
on a whole nother level. Yeah.
That's my point of view on that is it's a free country. Let people do what they want to do. And he should do whatever he needs, whatever he wants to do. But he does have a platform and
Right.
there are young kids watching. And I don't know, maybe he didn't sign up for that,
Yeah.
but he should be conscious of it.
Right.
Maybe like, at least say, kids, don't try this at home.
That would be nice, just because I think a lot of people are misunderstanding what's
Oh,
happening
yeah.
there.
People take it very literally.
Yeah, very.
Yeah.
And they're like, I'm going to
Mhm.
do everything he does. I said, but that's his life. He's doing something different. That's not what this is about.
It's not, yeah.
We're in the middle and we're just trying to live healthier. That way,
Yeah.
you're not a burden on your children later.
Mhm.
And you don't end up in a nursing home in a walker. You want to be thriving and running around with your grandkids at that
Mhm.
point if you have them. You want to be active. That an active lifestyle is what we want to focus on.
Ex
So,
I just made my mom goes to a gym. She
Mhm.
has a membership. And I just moved back to the area, and
Okay.
I'm gonna go to her same gym, and we're gonna have gym dates,
Oh,
and
wow.
I'm making my sister join the same gym. We're all gonna go to the gym together. We're all gonna lift weights. I'm making
That's
them.
Listen, you keep yourselves accountable that way, I think.
Yeah,
And okay, let's go. We got to go.
and
If
it's also how
somebody
we're gonna
doesn't
spend
want to
time
go,
together.
yes, it's
Yeah,
quality time and doing something that
exactly.
you all enjoy and can be a part of. I think that's
Yeah,
great.
it doesn't have to be a vineyard.
That can be later, but you can do the
Yeah,
gym first
yeah,
and do
yeah.
the weights. What is in your mind? And again, you have a long ways to go, so you're just starting out on the journey.
Mhm.
What does thriving in the 40s and 50s look like for you? And what steps are you taking to optimize yourself?
Oh, personally. Yeah, so I try to have a very balanced life. I don't do well in either extreme. I am very conscious of what I'm eating, but I don't get too nitty-gritty in the details. So every day I have a relative protein goal. I don't count the exact number, but I get around 90 to 100 grams of protein every day. And that suits very well for me. I previously I'm in such a transition phase right now
Right.
because I was in residency and that is just like a crazy time. But now I lift weights twice a week and I rotate what I do. And I'm just someone who I played a lot of running sports when I was younger. I played lacrosse since fifth
Mhm.
grade and would preferred being on attack and played rugby and played field hockey. So cardio is just something that I love to do and just running for a long time, listening to music, I love that. And so now that I've gotten older and I'm approaching 30, I've made a point to add strength training. And if anything, I wish that there had been more of an emphasis, I think, in high school on strength
Mhm.
training for girls' teams
Right.
because oh, this is something I feel passionate about that is coming up. The boys' football team
Mhm.
in high school would have scheduled gym lifting
Right.
sessions, and
Right.
so would the boys' wrestling team, and honestly, maybe a lot of the other boys' teams, but that was never a thing for any of my sports teams. And I started off freshman field hockey lacrosse and then JV field hockey lacrosse and then varsity lacrosse. And we never got scheduled gym time. And so I just don't think that it's so systematic or systemic in our culture that we don't even recognize it. But it's this lifting weights is not geared towards girls from a young age. And so that's something that I have had to change getting closer to my 30s is that no, lifting weights is something that I do too.
Right.
And being conscious of how much protein I'm eating to build muscle is something that I do too. And yeah, and taking care of yourself as a whole person.
Right.
Your mental health is huge and
Mhm.
your sleep is huge. I had crazy insomnia in residency from anxiety. You're just lying in bed ruminating over how you have to get up again in 4.5 hours because the shift you're on call or something, and it was a crazy shift, and you haven't even unpacked all of the emotional things that happened on your shift. When you're a resident, patients pass away, you do new admissions where you have to escalate care quickly to the ICU. You're in family medicine, you could be sending someone off to the ICU and you could be delivering a baby in the same shift. And you come home and you have a couple hours to sleep and you don't have any time to unpack. And so just lifestyle balance is not a thing in residency. So now I feel like I have to play catch up in my 30s, which is going to feel probably great and feel a lot easier than going through residency or medical training.
It's a new start, and basically you can craft it the way you want it to be, I think.
That sounds great.
That's the whole point of private practice, or just when you get out of training, because we're
Yes.
brainwashed. Training is brainwashing, basically. You go, you
Yes.
don't ask
Yeah.
questions.
Submissive.
Yeah, you're not a person, you're just a
No.
resident. You don't have a life and don't even think about having a life. Now you come out and you realize, hey, it's a bigger world out there,
Yep.
and I do have a right, and I do have time
Yeah, you're
to
like,
take.
wow, I'm actually a valued member of society.
And it changes your outlook on things, but it's slow going.
Yeah.
But it comes around because we all come out of that fog after a few months, and we're like, wait, hold on. I am a real person, and I can take vacation and not feel guilty about it. And I'll come back stronger and take care of my patients even better because I'm well rested.
Yes. And honestly, you have more money to spend on healthy food.
Yeah.
And you have more money to, wow, you can go take an exercise class. You can actually pay for stuff like that. So I think that this is actually a really important topic, is women in medicine who go through medical training and the way it actually impacts us, the way that it impacts us physically and psychologically, emotionally is very different, because we are different than men, and the female resident experience. We need to talk about that.
That's a whole other podcast.
That's a whole other
episode.
podcast. I'll come back. We can talk about that.
We
all
need
day.
to do that. It's funny. I had that whole discussion with Sharon Malone. We were in a room a couple months back, and it was insane. We were all saying the same thing. That struggle that we went through, like, we were proud of it. Oh, we made it. But why do we have to be like that? Like, that, it was craziness. But we're all saying the same things, and we're all within a few years of training of each other.
Yeah.
And it's really like it's a mentality that we were taught, and we have to break those cages and get out of them and be like, okay, this is where we're headed. This is what we're doing. We're good people. We want to do well, but we also should be taking care of us and us.
Oh, you know what we should do? We should do like a round table.
Yeah, that would be
Why don't
fun.
we should film a round table
We can do that. Absolutely.
of only women, obviously. And I think different specialties is important.
Yeah, just to get different takes, because each one is like primary care, family practice, OB.
Yeah.
Like, it's all nuts. It's all crazy.
And like urology surgery would be crazy to go through. I don't even know how they treat their women there. I have no idea. Or like ortho, that would be crazy too.
That would be fun. Yeah.
Anyway.
Sorry.
Oh, sorry.
Yes. Let me.
Oh, sorry.
Red. That was a good one though. Yes. Yeah. I think I have one more question, Red, and then we're good. No. Okay. This is a good one to end it on. How do you think the narrative around women's health, aging, hormonal health, all of that is shifting specifically for your generation? How do you think it's shifting, and where do you think it still needs to go and evolve?
I think it's shifting in a positive direction because of the vocal leaders that we're having that are female physicians on multiple different platforms, posting on social media, all the way to meeting with government. But I think that there is a lot more room to grow. I got zero training on prescribing testosterone at all in residency. If I've had male patients with hypogonadism, clinical hypogonadism, who I've either continued their testosterone or started them on testosterone supplementation. But because it's currently off-label, and that's why FDA labels are so important, because it's not going to be massively or routinely adopted until we remove certain labels or get it approved for certain indications. But nobody is getting training in residency that I know of in supplementing testosterone. So coming out of training, I think me and along with a lot of other family doctors in the US will feel comfortable prescribing estrogen and progesterone. But yeah, so that is one area of improvement that I think we should talk about it more.
Right.
And even if it's off label, if we're doing transdermal testosterone at a physiologic level and we're managing any kind of complications and titrating very minimal doses, we should give women that option and
Right.
we should start talking about it in training.
Is that something part of your toolbox that you use for your peri and postmenopausal women, testosterone?
I, coming out of training, have not, but it is. I think we owe it to our patients to always have training in something before we do it. And I
Right.
think that there are a lot of people out in the community doing off the cuff things.
Right.
And we should be taking responsibility for our patients and feel comfortable prescribing things and being able to manage the complications. So there's a lot that I want to do, though. I think that learning and training is almost can be just as much as residency, if not more, depending on your own attitude and how you go after things. So there's the menopause certification from the Menopause
Mhm.
Society, and there are leaders in the space, such as Dr. Rachel Rubin does so much
Mhm.
training and teaching, and Dr. Heather Hirsch has her hormone course, and there's just people to learn from. And
Right.
my eyes are very open. And I think if I go after those learning opportunities, then my patients, I do it for the patients.
And they're going
Yeah.
to get the benefits because you're gonna have that comfort
Yeah.
level with
Exactly.
prescribing all of them. And
Yeah.
that way you're giving them everything they need because we do tend to fall into that category of just stick to the rules and go by the guidelines and do the estrogen and the progesterone. But yeah,
Mhm.
testosterone is another big component of it. And you need to be, again, able to manage the patient and understand
Mhm.
what their needs are and where does it come into play and what form of it comes into play
Mhm.
because there's all different varieties of all of them. And
Mhm.
how do we know what works well? It's very personalized and
Exactly.
we need to be very careful with what we're doing, but also
Mhm.
not scaring patients off either.
But the nuances of what you just said with all the different kinds of hormones, that's not being taught.
No,
No.
no, not
That
still.
is
Still not,
not
yes.
no. The art of that. There's an art
Mhm.
to every part of medicine and the art of prescribing hormones with the intricate details that is not being taught at all, and that is something that you as a resident, you have to go for on an individual basis, and it was so fun learning that it doesn't all stop when residency ends. You are gonna
Yeah.
learn your entire career. That's the point of being a doctor is having an open mind and being a lifelong learner and going with the times, and it's almost exciting being part of it,
Yeah, and there's
learning about all of
evolution.
it.
Yeah, there's
Yeah.
evolution happening and there's research coming out. So we're all learning still. And I think when you find an doctor who says, I know everything and I've learned it all, that's where we know we're not doing well because we're
No.
always training and retraining and learning and taking different
Exactly.
certifications. So let me ask you one last thing. Where can our viewers and listeners find you?
So I'm mostly on Instagram at Dr. Kazarian, and the purpose of my platform has been to talk about primary care. It's not to talk about extremes of health or it's just to bring general health education, talk about relevant topics in primary care, making primary care cool, and also talking about the US healthcare landscape
Mhm.
and the things that are currently going on in our country because it is so intricately combined with primary care and the way that I can practice, especially for our patients. The practice where I practice, we take Medicaid and Medicare, and it impacts my day to day conversations. So that's what you'll find on that page.
Great. Beautiful. Thank you so much for being here today.
Thank you so much for having me. This was amazing, Dr. Jila. I'll come back anytime, seriously.
Yes. No, we'll have you back because now I like that whole idea of the round table. I'm gonna
That,
have to talk
yeah,
to Red and see how we can figure that out,
be
but
so
that's
fun.
amazing.
Yeah.
Yeah, I love it. I love it.